You're listening to In Sickness, a caregiving podcast from the Negative Space with Allison Breininger and Justin Bima.
Good morning, Justin.
Good morning, Allison. We have a guest with us today. We have Alec Wendelboe here to talk to us about suicidal ideation in patients and caregivers. And so we are going to be talking about suicidal ideation, things of that nature. So if that's something that is triggering for you or something that you just don't really want to listen to right now, hit stop. That's totally fine with us. If you want to come back to it later in a better time, feel free to do that. But yeah, if it's not for you today or later, that's fine. So
thanks for that. And welcome, Alec. We're so excited to have you here with us. Thanks for being here.
Thanks for having me, you two. So excited to be here.
Yes. And so your work is with the Minnesota Brain Injury Alliance and the Minnesota Stroke Association. And we're going to hear today about how your work there relates to this topic. But today, because we have listeners who are caregivers for people of all types of injuries and illness. And so today we're going to cover this topic as it applies to caregivers and patients of all kinds, correct?
Yes, exactly.
Great.
So can you start by defining for our listeners what is meant by suicidal ideation?
Yes, great question and a great place to start. When we're talking about suicidal ideation, that would really be thinking about or having thoughts of suicide. May not necessarily mean the individual will act on those thoughts, but the person is really thinking about suicide and may or may not be making plans.
And what are the other, if you think about that, then are there sort of steps, right? You said the plans, right? Thinking about it, like, is there sort of, is there another step beyond that? Or is it sort of like a continuum, if you will?
Great question. When we're looking at those different stages of suicide, we might see the person kind of waxing and waning out of one stage into another. So we might see them experiencing a little bit of that light suicidal ideation, kind of transitioning into something more severe. We can't say for sure, this will make the person act or this will make the person less likely to act. So it can, of course, really be a lot more individual into how that person is moving through those stages. A really good question if we'd say, is this suicidality? Is this suicidal ideation? And what the differences between those two might be, but very similar in those two topics, I'd say.
What do you mean when you say suicidality?
Yeah, so that's really more just the overall thoughts of suicide, maybe not so much the person acting, but more their overall maybe kind of a hard question to answer.
Is that a step that precedes suicidal ideation, or is that a general thing that includes it, I guess?
I would say generally includes it, more kind of parallel together.
Yeah, okay, great.
Sure. And I've heard that before, that if someone is saying to you that they're having thoughts, that a question to ask them is, are there plans? Are you making plans? Or do you have, what I mean? Is that sort of the next
Exactly.
stage? Okay.
So we might see the person having those thoughts, but not making plans. Okay. And then we see the person having the thoughts and making plans. And of course, that's when things get more serious for that person.
Okay. Got it. Thank you. That's helpful.
What can you tell us about the rates of suicidal ideation experienced by people with chronic or other medical conditions compared to their peers that are healthy?
Yes, a really, really good question. When we see chronic condition, we see a lot of changes, right? Changes in how that person goes about their life, how they see themselves and their identity, and how they interact with family and people in their life. And of course, these changes can really cascade into all portions of, how that person lives their life. So when we're seeing those changes come up, they can really be feeding those levels of suicidal ideation, where if the person isn't doing what they did before and isn't feeling like they did before, it can make it a lot harder for them to push forward and to keep moving forward and to see the motivation to keep going.
Mm-hmm.
So we do see some differences depending on different chronic conditions. Of course, my work is largely centered in the brain injury and stroke sphere. And the reason why I'm here having the conversation today is because of that really strong overlap. Mm-hmm. Specifically, when we look into traumatic brain injury, we see that rate of suicidal ideation being about 9 times higher than when compared to other chronic condition types.
Okay, wow.
When there's a brain injury. Okay.
Exactly. Okay. And there are, of course, some other chronic conditions we see being linked pretty closely. One of those being chronic sleep disturbances. increasing that rate of suicidal ideation by about 2 times. And then HIV/AIDS being the one coming in there at third, again at about 2 times. So we do see some differences depending on what kind of chronic condition we're seeing, what stage the person is at in their condition, and of course, their functionality.
Right. So my awareness of like suicidal ideation is generally in the context of depression, right?
Yeah.
As that's, I think, typically where there's that conversation where you have depression, you're depressed, and that's a direction you could move. I've also heard it in context of like specifically conditions where there is a great deal of like chronic pain.
Yes.
And it's just life feels unlivable in that state. When you're talking about like the brain injury aspect of it, is it related to either of those, or is it due to like a change in the brain itself? Like, how do those aspects kind of weave into what your work is there?
I would say a little bit of both on that end. And one of the phrases I always like to use is a brain injury can change anything, but it often changes everything for that person. So for instance, let's think about your memory, right? If your memory changes, you're changing the way you think about yourself. You're also changing the way you reflect on your past. And that kind of bleeds into how you have your friendships, how you see those friendships, and really all portions of how you think about your life. So when we're talking about suicidality in the context of brain injury, we always have to consider that it could be just one change that's really significant, but it could be that change is really webbing out into all other factors of that person's life. So it could be the physical health side of things, right? Maybe they can't do as much as they would have before, and that's making them feel bad. Or it could be the mental health side of things. They're struggling to get motivated. They're struggling to keep going. Or, of course, it could just be the stress of recovery, right?
Yeah.
So it's with the brain injuries, is it, correct me if I'm wrong, is it not so much that the brain impact, like there's an impact on the brain that causes this? It's more that the impact on the brain is causing life changes, which makes someone say like, whoa, I can't do this. Is that?
Exactly.
Oh, interesting. Okay. Because if you think, go ahead.
Oh, I was just going to say, it can be a little bit of both sides as well, where we could see maybe some structural changes in the brain that are impacting, say, like coping skills or the individual's ability to react. But it could also be the life changes that are a little bit more tangential to what's really going on, but still playing into those feelings.
Interesting. Right. Because, so we have a lot of, like Justin's wife and a lot of our listeners have ME/CFS.
Yes.
Familiar with that? And Justin, I don't know if you're familiar with this, but I feel like I have heard that there's a higher rate of suicidal ideation in that community.
Right.
Because it's lifelong and it's not terminal, right? But it's this lifelong thing that you're going to be dealing with, right?
Yeah. And I think on top of that, like a incredible lack of medical understanding, medical support, treatments, all of that probably plays into that as well, where I can see how it would be very easy for someone in that state, in a severe form of that, to feel like there isn't hope that things are going to get better.
Right. Yes.
Totally. Yeah. And just that overbearing pressure. I think a lot of folks with chronic condition are, of course, really bogged down with that pressure of, when will I get out of this? When will I be able to move past the chronic condition and go back to life as it was before? And of course, that can be so stressful because if we can, it might be a lot of work that we can't do right away. And if it's less so attainable, we might be setting ourselves up for a lack of success and really decreasing that motivation.
Sure. Well, and I appreciate what you said, Justin, too, about like, and if you're in this situation, you're like, the doctors aren't helping and the research isn't there. And like, there is no, like, this is it.
Right.
And sometimes I, as a caregiver, feel like with my husband's chronic condition, like we're either going to be in this state, which is hard, or worse. Like there isn't like a better version.
Right.
And that is a really hard place to be sitting in. His is, and we've had on the show, Megan Voss, who is an incredible researcher and therapist. And she and others have been doing research on the mental and social impacts of Fanconi anemia, which is the illness my husband has, on those patients, because it is chronic. And it is the kind of thing where like, oh, cool, you got over this cancer. Great. Another one's coming. Right. And so it's just this like, how do you keep moving on knowing that it's going to, the shoe's about to drop. And I feel like that's a phrase I hear from caregivers all the time. It's like, I'm just waiting for the next shoe to drop.
Exactly.
Yeah. Yeah.
And I feel for a lot of folks who are experiencing chronic conditions, because of the nature of the long-term standing, at some stage, they're going to look or appear similar to how they did before. And for many of the folks we work with, once you get to that stage of looking comparable, you have so many folks in their life saying, well, they must be fine.
Right.
They're looking better. They must be doing fine. Let's get them back to work, get them back to school. And then we're not focusing on what that person is still struggling with or still working with on their day to day.
That makes me think about in cancer survivorship. It's like you ring the bell and everyone's like, great, you're done. And more research is starting to be shown, and that like for the patient and the caregiver alike, that emotionally after the treatment is over is when it hits. And it's really this lifelong thing that you're dealing with, even if maybe you're cancer free at this moment. But your life, people are just like, you're good. Treatment's over. Off you go.
On your way. Exactly.
On your way. Right. Yeah. Your hair grew back. Okay. You must be fine. Right.
Yeah, we're doing well.
Imagine that those pieces of people no longer giving you the sympathy or the empathy or the support can add to these feelings. Is that true?
Exactly. And it's really tricky because if we have someone who maybe does not have some of those physical appearances to their disability, then often they're not going to be given the same respect, the same grace, the same patience that somebody else might be. But then on the flip side, if we have a more obvious physical disability, it's going to be more likely that we experience discrimination or retaliatory action or other issues. So on either end of that coin, we're really struggling.
Oof, that's powerful. Yeah. I'm going to be thinking about that one for a while. I want to stop to say, because if someone, like we had a traumatic brain injury speaker on the podcast a couple months ago, and so for some of these things, like you said, if you have a traumatic brain injury, it's 9 times more, right? Like, but what if I want to ask that, like, conversely, is it the opposite, that like, okay, my person has a traumatic brain injury, therefore that means that they are having suicidal ideation, or my person has ME/CFS. Does that mean, right? Is a flip side true?
Good question. And not always definitively.
Okay.
There's going to be maybe a higher chance that that person is experiencing suicidal ideation alongside that condition. Of course, we can't say for sure, but a good reason to think that it could be, I guess.
Sure.
Right.
I'm just thinking, should people panic?
Definitely not.
Right?
Definitely not. Yeah. I think one of the biggest factors to keep in mind, especially when we're talking about brain injury and suicidal ideation, is this typically doesn't start right away, right? This is the person seeing those subtle changes over the long term, and those emotions are kind of feeding in and increasing it in the long term as well. So a lot of the research would indicate that suicidal ideation risk is going to persist for at least 15 years following something like a brain injury. Now, the troublesome thing there is the studies capped out at 15 years.
Sure.
So there's good reason to believe that would persist longer. But of course, it can wax and wane for that person over time. Maybe they'll see an increase in skill and be feeling a lot better, and then maybe have a second issue come up and kind of feed back in a little bit more. So like I say, really waxing and waning over time for many of us.
But is it compounding, do you feel like, as the time goes? If it's a chronic thing, like, is it building as it goes?
It can be. And it can be if we're seeing that cumulative effect. Or maybe the person is dealing with both brain injury, or maybe both stroke and diabetes, or dealing with cancer and asthma. And now we're seeing those kind of compound together and become more serious for them.
Sure. Yeah.
So we've talked about patients, people with chronic conditions, brain injuries, all of that, and how suicidal ideation is increased there. Earlier, as part of that, you were talking about like how the severe life change and like, will this ever be different, can feed into that. And that's certainly, those are thoughts that caregivers have as well.
Yes.
As they are alongside their person through these situations. So is there any research on rates of suicidal ideation in caregivers? And if so, does that connect at all to the length of the illness or injury on the person they're caring for?
Fantastic question. Unfortunately, our research is still more limited in this sphere. There is more research being done really looking into caregivers, but as you guys well know, at the negative space, it's often not the first person to be considered and not the first person to do research on. And, when we're doing things like trying to secure funding, it can be hard to long-term look out and say, how will we do this for our caregivers? How will we do this for others?
I mean, I think that what we hear, here is, and I know that there's research around things like caregivers have 90% of caregivers experience anxiety every day.
Yes.
Right. I think it's, I wish I had the number in front of me. I'm sorry, but the rate of depression of a caregiver is so much higher.
Yes.
Right. Than our peers. And so I think that we can, maybe extrapolate that if we know some of the things, there's been some research on at least the mental health aspects of it, and that, how might that play out? But it's sort of like what you said earlier, Justin, about the, like, when you're not being respected, their research isn't being done, then that can also feel like, guys don't even care enough about us fast and to do the research on us,
Exactly. How frustrating.
Yes. And how feeling unseen and feeling like we're in the negative space, like you said, right? And so, but I think that, like you mentioned, Justin, like, our life has changed. And for us, for both, I guess I shouldn't speak to you, to your experience, Justin, but for myself, I'll say that, like, this is a long-term, like, I've been in this for 14 years,
Yes.
And there's no end in sight. And the end that it might be in sight is death for my person, right? And so for me, it's thinking, like, okay, so I'm either going to keep doing this really hard thing, or he's going to be gone. I don't like either of those options.
Right.
Exactly. How do you contend with those two, or even justify to yourself how you're feeling when those are the two options?
Right. And I will share that I was quite recently actually in a pretty low moment of, like, I said to someone, I'm like on a merry-go-round from hell. Like, we're just like, keep going, doing this thing over and over again. And I will share that my brain went to a place of, I can't keep doing this. And then I had this fear, this, like, sort of, what brain? What did you just say? Like, it was almost this, like, shame of, like, and fear of, like, uh-oh, what's going on in my brain that my brain just said that? And now, should I be scared? And is there something wrong with me? And should I be calling 911? And do you know what I mean? And so fortunately, I have this amazing therapist who was like, Allison, of course your brain thought that. Like, you are on overdrive. We talk a lot about the nervous system and the window of tolerance here. Like, your brain is, like, trying to support you. It's trying to shut down. And of course it's saying, I can't do this.
Exactly.
And she helps me take sort of the shame and scariness out of it, and to say, like, that doesn't mean that there's something terribly wrong with you. That doesn't mean that something's about to happen. That means that your brain is saying, this is a lot.
Exactly.
And that was so helpful for me to hear, because my brain heard myself think that, and then got really scared.
Totally. And I feel many of us as caregivers will relate to this the self-shaming of it all, of saying, well, I'm struggling, so it must be something wrong with me, or it must be something that I'm not doing right. And we're not really giving ourselves that patience to say, no, this is hard. You've got a lot going on. You've got a lot on your plate. Anyone would struggle with this. And really that shame, of course, can be kind of oriented in either direction. It could be the shame of saying, well, I can't be thinking this because I need to be strong for my loved one. But it could also be the shame of, well, why are you feeling that way? That's a selfish way for you to think. And frankly, neither one of those two are exactly helping the person realize why they're feeling what they're feeling.
Yeah. I think it actually felt like a scary, like more of like a symptom. Like, it felt like, oh man, is this like an alert? Like, do I need to, like, does this mean there's something going on with me? And do you know what I mean? It was more of like that, as opposed to just like, no, that makes sense that you would think that.
Exactly.
Yeah, no, I can certainly. So as I've talked about here, lived with depression on and off for a long time, right? And certainly the years where Sarah was very sick, the years where she was in bed, that was not a helpful situation for my depression. And so I can understand the compounding factors of being a caregiver and the impact on your mental health and all of that. And, certainly at times with my depression, I've experienced some light suicidal ideation, things like that, certainly. And it has felt to me like something that, because of there's still a societal sort of stigma around that type of thing, that it wasn't even something that I brought up with my therapist right away. Like, it felt like if I said that, like, suddenly it would be opening up this like crisis or something. And there would be like, we'd enter into this series of events that would like being like evaluated. Like, suddenly things would be very serious.
Totally. Like the white coat hellscape of it, where you're fearful that just starting that conversation will just bring the cavalcade of resources and help your way. And you're saying, I don't need this right now. I just need somebody to talk to.
Mm-hmm.
Yeah. And I think part of, too, for myself included, the nuance between having thoughts of, this life is too hard. How can I keep living this life? There is distance between that and actively making plans to end your life.
Yes.
And one doesn't necessarily lead to the other.
Right.
And feeling like if you talk to someone about that, bring it up with your friends or a friend who's supporting you, like, they're not going to understand that nuance, and they're suddenly going to be treating you differently because they think that you are suicidal.
Mm-hmm.
And so, yeah, I think those are compounding factors that lead to you trying to manage it silently on your own, which is not the best way to deal with feelings like that.
Exactly. And that's really one of the biggest elephants in the room that I want to talk about today.
Please.
What we really see is this relationship between suicidality and male groups, where men are at a higher likelihood of experiencing suicide itself and acting on those thoughts, but across the board report lower levels of suicidal ideation when compared to women. Now, what that tells me is that the men are likely experiencing the same degree of suicidal ideation. They are just reporting it less frequently. And if they're less likely to report, they're less likely to talk about it, less likely to reflect on it, and more likely to act on those thoughts, which of course makes it really troublesome. You want the person to feel comfortable having these hard conversations, or at least bringing it to the foreground. But when this stigma surrounds it, it can make people feel stuck.
Mm-hmm. Yeah, no, I can certainly, I went through, I don't remember how long, a number of TMS sessions a few years ago for my depression. And every week when I went in, they had I don't remember what the form is, but it's the standard depression evaluation form used in psychiatry. It's, I don't know, 10 questions or something like that, and you get a score. Tracking how that was going, right? But one of the questions is regarding thoughts or plans to harm yourself or end your life, things like that. And even if I had some light suicidal ideation around that, in that time, it felt like if I checked that box, suddenly I was going to be in a psych ward or something like that. And it was going to, things were going to escalate. And then at one point I was just I checked it, and the tech just very calmly asked, okay, is this something where you have any plans, anything that we need to be concerned about? And I was like, no, not at all. And she's like, okay. And it wasn't a big deal.
Yes.
Mm-hmm.
And that felt really good.
Exactly. Because so many of us, we don't know what the reaction is going to be when we tell our friends or our family, and we can't know what that reaction will be. So instead, we're just thinking about it and kind of anticipating what that response would be, and often giving ourselves the worst expectation. I mean, how many of your friends and family, if you told them you were struggling, would say, how can I help? What can I do? What can we do to fix this? But when we're thinking about it, how likely are we to say, they'd be mad at me, or they'd be upset with me, or so on and so forth.
Sure.
Well, and even there, I can see the response of, okay, how can we fix this? Like that, as the person that does, I mean, I understand that they want to help, but it's also
too much,
a lot to take, and it makes you feel like it reinforces that there's something wrong with you.
Exactly.
Which there may or may not be something bigger going on there, but it feels like that's a response that means, okay, it's bad that I'm having these thoughts and I shouldn't be. And it kind of can, I don't know, I could see it reinforcing the stigma a little bit around that.
For sure.
Totally.
Yeah.
And often, that's kind of people's first reaction is to say, what can we do? How can we react? And a lot of times people, that's not what they're looking for. They're saying, we don't need to do anything right now. I just wanted to get this off my chest.
Yeah, I just want
and just having that conversation was so much to get past that threshold that they're pooped,
Yeah. I think it's interesting, Justin, that on that form they had thoughts and plans in the same checkbox, right?
Yeah, and
to me, it seems.
I don't remember the exact form, but I feel like there's just a single question around that.
Right. Right. Yeah. Because I know that even when I brought this up to my therapist, I was like, I don't have any plans. I don't have any plans. I'm just telling you that this is my thought, And for me, it was so far helpful that she was just like, of course you have that thought.
Right.
I was like, oh, what? Like I love that phrase, of course. Like we say that to caregivers all the time. Like, of course you're overwhelmed. Of course you feel resentful. Right. And so when she was like, of course you're having that thought. Why would your brain want you to keep going through hard things?
Exactly.
And I was like, oh, okay. Like that was so helpful to have that, like that, the reiteration that like, you're not broken. There's not another thing. There's not, because I think for me and for probably other caregivers, like our plates are already overflowing. And so it's like, I don't have time to have a thing going wrong with me. I don't have time to go, like get this extra support. Like I don't have time. And so to think like, is this thought mean that I have extra needs that are going to need to, right? It's like, I can't go down because my person, you know what I mean? I'm the caregiver.
Yeah. And often that pressure that we're holding on ourselves is one of the driving forces in itself, right? That pressure of saying, if I don't do this, nobody will.
Right.
Or that pressure of saying, if I'm not there, nobody's there. Or if I don't, and it gets people in this state where they're focusing too much on what they're not doing and not focusing enough on the successes that they're already making with their loved one and the progress and all the time that they're already pouring in.
Sure. But I can hear caregivers hearing that same thing, and that might be the thing that's bogging them down. I am the only one. Like if I go, then what, right? Like everything is balanced on me, and that feels like a lot, right? Yeah.
Yeah. And in that line of thought, then, you can't go. You have to stay around for your person. Like suicide is not an option for you because then what happens to your person? I can see how, you have these thoughts and like you can't even I don't know. I feel like it would be a lot of feelings around like, but that's not even something that I could consider.
Right.
Because then what happens to my person? And it's like the level of like mentally feeling stuck in that I can see would be really, really tough.
Yeah. Like, I don't even get to make that choice.
Right.
I don't want to say it in a weird way, but you know what I'm saying? Like, I don't
totally.
Like, I am so dependent upon that I don't even get to make that choice.
Right.
Yes. Feeling like we're trapped in a box and not knowing how we can get out of either one.
Yeah.
Yes. Yeah, exactly. You said the thing about men and how men are, the demographics. Are there other demographics that make somebody more at risk?
Yes. It does seem that one of the other big demographic features would be the severity of that injury or condition itself. Now, while we have this conversation, I always like to give a little caveat. So, you'll typically hear the phrase mild, moderate, or severe. Certainly for something like brain injury, you're a mild brain injury survivor. You'll be okay in a few months is the phrase we often hear. Now, often the symptoms that the person experiences are not exactly reflective of that clinical severity. So if someone goes in with a mild brain injury, that doesn't necessarily mean they're going to have all mild symptoms. So I always like to give the caveat to focus more on the symptoms that the person is experiencing than that clinical category, just because it's going to be a little bit more respective into what that person's, going through.
Sure.
But the research does seem to indicate that folks who have a more mild condition are about 2 times greater risk of experiencing suicidal ideation. But when we get into more moderate or severe conditions, we see that risk going up to 3 to 4 times. So, of course, the actual severity of the condition can certainly play in, not to mention things like racial and ethnic factors. It does seem that Native American, Alaskan Native, Hispanic, and Black populations are at the greater risk.
I mean, we know, there is systemic racism embedded into this country. Are there reasons that you can pull out around that? Is there cultural stigma in different, talking about it? Or is it, do you have,
Certainly.
extrapolate, but do you have ideas around that?
And of course, mainly from the stroke perspective and brain injury perspective. But it does seem that, for one, folks who are in rural Minnesota or rural the United States are less likely to be discharged to care facilities and less likely to be given those follow-up resources. So that's one of the biggest factors. If somebody's outlying in whatever state you're in,
sure,
it's going to be a lot harder to get them resources.
Sure.
And we might see those issues kind of coming up from there.
Sure.
Not to mention just the overall access of resources.
Yeah.
Specifically, I work really closely with a lot of our tribal nations in Minnesota. And it's just really disheartening to see how few resources there are for some of these folks. And if the resources aren't there, how can you do anything to combat it?
Absolutely. Yeah. Oh, and I'm just thinking about, I know that a lot of the rural things are about to go away even more.
Yeah.
Yes. Very troublesome.
Rural areas. Yeah.
Yes.
Okay.
So for caregivers now, if you're a caregiver listening, maybe now you're suddenly concerned that this is something that you need to be watching out for in the person you're caring for. So what are some things to watch for, signs or symptoms that as caregivers we can be looking out for to see if our person is moving in this direction or could use more support around this? Absolutely.
So when we're talking about the warning signs or things to keep an eye out for, the biggest thing to keep an eye out for is this behavior new? Is it increased, or is it tied to a particularly challenging life change or life event? That could be a really clear indicator. Maybe this person has had issues with substance use in the past, and that doesn't necessarily mean substance use now would lead to suicidal ideation. But maybe if they've never had issues with agitation in the past and you're seeing them come up now, that could be more of an indicator than not. But across the board for both adults and children, the biggest indicator would be talking about suicide, making plans, or expressing to others that feeling of hopelessness.
Mm-hmm.
For adults, we might see more of that anxiety, that agitation, and especially the impulsivity, where the person is looking less into what is the long-term action or the long-term reaction to what I'm doing, because we're focused more on the stress and everything going on now. Of course, we might also see an adult talking about being a burden or talking about feeling like they're trapped, or even that increased use of substances. Maybe they were using a little bit before, but it's getting a lot more serious now. We could also see the person sleeping a lot more, or maybe even not sleeping at all. They're staying up throughout the night and just running through. Or we could see the person is showing rage or feelings of wanting to get revenge. Or even those folks displaying those extreme mood swings that are really rocking back and forth. When we look more into youth groups, that could be displaying that overwhelming stress or overwhelming emotional burden, or some certain changes in behavior. Often this would be something like the withdrawal, where the kiddo is withdrawing from things they would have done before. Maybe they're becoming more angry or more hostile, or maybe they're getting a little bit more irritable more often. Of course, you know your loved one best, though.
Right.
So if you're seeing something and you think, well, this isn't out of the norm for them, then it probably isn't. But if you're seeing something that really seems like a significant change, then maybe good to make a note of.
And then beyond making a note, what do you do as the caregiver? I mean, do you bring it up with the person and have a discussion with them? Do you just kind of make a note and then just kind of, okay, the check marks are kind of adding up, things are maybe becoming more serious and there's more intervention needed? Kind of how do we approach that?
Good question. It does depend on the person, of course.
Right.
What I often like to recommend is trying to make sure we're giving that survivor or that individual an opening, making sure that we're making ourselves available so that if they want to have that conversation, we're ready for it. But often what's going to be less helpful is forcing out that conversation. Because if they're not ready to talk about it and they're not ready to bring it up to you, they just might feel too much pressure being forced to disclose or being forced to, even think about it with the person. So I'd say maybe the best tip in that initial stage would be make yourself available.
Right.
And instead of asking directly, maybe just ask some probing questions like, how are you feeling today? How are things, changing? How can I be of help?
Well, I think I always love when there's something like this podcast, right? Because then a person could say, that podcast I listened to, like they just had this guy on and he was talking about this and about rates. And I was just wondering, like, to have something like this, like I just read an article, I just heard a thing as an opening, as opposed to just like out of nowhere being like, hey, right?
Yes, exactly.
It's more of a curiosity, like, I just heard this thing and some research that they said was da-da-da. And I wondered like, hey, is that something that's ever like occurred to you, or how do you relate to that?
Fantastic foot in the door. Totally.
Yeah, for sure. Because I wonder, you named a lot of like outward symptoms, but some of the stuff like Justin, you said it was in your mind for a long time, right? And so that's the other thing is knowing, is it in their mind? Is it not in their mind? You know what I mean? And so to sort of have that, like you said, like that opening of asking some questions, because you might not see outward symptoms, right?
Exactly.
Yeah.
So we talked a little bit about how to handle this, or what signs to watch for with the individual who's ill or had a injury or whatnot. For caregivers who are having these thoughts, having these feelings, what should they be doing?
So I like to use a couple of different analogies when we're kind of comparing the survivor or the individual and the caregiver. So maybe let's start using the survivor analogy.
Okay.
So I like to use a jar of change. So think about your mental energy, your physical energy as that jar of change.
You say jar of change, like jar of like coins, you mean?
Exactly.
Yes, okay, got it. Okay.
So let's say for a neurotypical brain, the person gets good sleep. They wake up the next day with that full jar of change. Maybe they brush their teeth, spend a nickel, make their breakfast, spend a quarter. But because we've done these things before, it usually lets us estimate how much will this cost me and kind of budget. But following the chronic condition, we see this becoming more challenging for the person for a couple of reasons. One, the brain and or body are healing while we're sleeping. So resources that would be saved for tomorrow are being consumed tonight. And after the injury or condition, it becomes much more challenging to say, how much will this cost me? Because we're doing things differently. And in our experience, this leaves many folks stuck where they get a certain way into their day, certain way into their week, and they're out of steam. And that's where we often see folks, lashing out. Maybe they're making reckless or impulsive decisions because we don't have the energy to keep those emotions down. So that's kind of the way I like to conceptualize it for the individual. But for caregivers, we often hear the phrase of, you can't pour from an empty cup, right? And I like this phrase, but I think it's better reflected to say, you can't boil an empty kettle. Because ultimately, you can. You can get away with it once, maybe twice, maybe 3 times, maybe a bunch of times. But the more times you're setting that kettle onto the stove with no water, you're warping that metal. You're distorting the kettle, and you're slowly decreasing the longevity of that caregiving relationship. So on either side of the coin, if we're running ourselves out to no energy, we have no steam to give, that's when we're really putting all that pressure on ourselves and making things a lot harder. So one of my biggest tips, regardless of which side of the fence you're on, is the body's going to let us know, right, in one way or another, that we're out of steam, that we're stressed, that things are becoming too much. I know for myself, I get a little cranky, right? I'm going to be a little bit more likely to snip at my folks or at my loved ones, right? For other folks, it might be you're sleepy or you want to go isolate. But once we can recognize what the warning sign is and where it's coming from, it'll give us a little bit more actionability to decide how we'll react to that and how we'll handle the situation. So of course, that's more of a long-term plan, right? But really just being introspective and saying, okay, how am I doing? Where am I sitting? And then kind of going from there.
Yeah, there's a theory really similar to your jar of coins, which is, or jar of change, which is the spoon theory.
Yes, we love spoons too.
Yes, exactly. Same. And I do want to say, well, so we on the podcast sort of hate the pour from an empty cup thing, and I'll just tell you why.
You and me both.
Yes. Because it is focusing on, it's saying that like my wellness is important so that I can care for someone else, as opposed to like my wellness is important, full stop. Right. And
exactly.
So even when you said, I love picturing, because I think that's how so many of us caregivers feel, like that, like burnt, crusty, eroded kettle, right? Like, oh, that's it. And so you said that could like then impact your caregiving relationship. Yes. And it's no fun to walk around living as a burnt, crusty, eroded kettle. Right?
Exactly. And building that resilience in your long term to say, I'm worth it. I better keep caring for myself, because if I'm already rusty, you know, how do I see my value?
Right. Yes. Yes. And I appreciate like when you said that, because I think even for myself, I think about that all the time, like about how many spoons do I have? Because I think at any minute we might end up in the ER and I'm going to need like 25 spoons. And
exactly.
So tonight I can't stay up late because what if, you know what I mean? And so even as the person who is quote healthy, like I am constantly aware, and that's exhausting to think about that. Like, oh, if I do this event, then what about that? And all of that. And to be like, just watching people go out and live their lives. It's like, well, that's cool.
Wouldn't that be nice? Right.
Amount of spoons. Cool. Happy for you. Right.
Totally. And really that thought of like, I am the on-call. I'm sure you two can relate to this. I know I can, but when you're the primary caregiver, you're always the one that's going to be called first. You're always the one who's going to have the answer. So if you're not prepared, then what's going to happen? And that overwhelming stress of saying, well, I have to be on call. Who else will?
When you said the thing about like the patient might not get good sleep because they're in sleep, they're healing, right? Caregivers often don't sleep well because we got one eye open, one ear open.
Exactly.
You know? Yeah. So I love those two analogies. Thank you for that. And I want to go back to Justin's question of like, okay, if I'm a caregiver and I'm sensing this, so because that was sort of like a preventative awareness thing. But what if I'm the caregiver and I am noticing these, like I'm using more substances, or I'm this, or I'm cranky, or, you know, all the things you mentioned, like what if a caregiver notices that about themselves?
I'd say one of your best ways to start is finding someone you're comfortable chatting with about this. Because I know for many of us, we don't want to put that stress on our survivor or the individual, right? They've got enough going on and we don't want to add extra stress to their shoulders. But if we're not getting it out, then it's festering, right? It's staying inside and we're not expelling it. So getting someone that you feel comfortable, even just briefly having these conversations with. And I'd say one of the biggest tips for long-term caregiving is kind of trying to eliminate this idea of we need to be the perfect caregiver, right? Because none of us are perfect.
Right.
We're all great caregivers, but none of us are perfect.
Sure.
And if we hold ourselves to that expectation, we tend to hold others to that expectation as well. So if it's 2 years into the recovery and I need to find a part-time nurse to help out my loved one, but I'm holding her to the expectation of perfection, I'm never going to find a nurse, right? I'm going to be searching forever. So instead, taking a step back and saying, I know I'm not perfect. I may be the best for my loved one, but that doesn't mean I need to be perfect, nor do they.
Sure. Yeah. 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 I think I had forgotten this about you, but you are a caregiver yourself, or have been. Is that true?
Yes. So what brought me to the Brain Injury Alliance and Stroke Association is I have 4 uncles, 2 experienced brain injuries and 2 experienced strokes throughout my time growing up. So it really gives you that sense of, well, let's be frank, the whole gambit, right? You're seeing someone who's well into their career and well into their life kind of going back and having to take some steps backward and see how do we move forward from here. And of course, 3 of my 4 uncles are thankfully still with us today. So, you know, we still support them as we can, but being that more tangential caregiver role for those folks, not to mention my folks with some health things themselves, but as many of us do. But, you know, the older folks in our life, many of us are going to serve as caregivers to some degree
Absolutely.
or another. And I often like to say, for many of us, it's not if, it's when.
Oh, for sure. 100%.
If it's not us who's the caregiver, it's us who are going to be cared for,
Exactly.
right?
Yep. Absolutely.
Yeah. I think another thing too for caregivers who feel like they're moving towards suicidal ideation or, feeling these changes, feeling more impulsive, whatever it is, reactionary. It's understandable that you're feeling that way, and you are not unique in that. You are not alone as a caregiver experiencing that. That is, if you're a caregiver and have not felt things like that, kind of surprising a little bit, maybe if you've been in it for a long time. And that's great. But yeah, it's not that there is something uniquely wrong with you. There are many others in this very challenging situation who have felt the same way. And I think in addition to, as you mentioned, finding one person to talk to, I think connecting specifically with other caregivers can be really helpful in that.
Yeah. Yes. And we're so glad because we're going to have a support group on this topic and Alec is going to join us. And so I know we're so excited. And so caregivers just know that is a space that you can come to and we can be together, and Alec will be there as our expert as well. And so also, I do caregiver coaching and this is not my area of expertise. And so I am happy to talk to folks, and I would be referring you off, like if there's certain things, then I can help you potentially like look for someone who is specialized in this. But if you just need someone to have a conversation with, know that the negative space offers coaching as well. What if it's an emergent situation, Alec? Like if it's not just like, oh, I'm noticing some things, but it's like if the person says, I have plans or I'm feeling like this, like what about those moments, either if we feel that in ourselves or if we are hearing that in our loved one? What about those moments?
Yes. My first piece of advice would be to look into something like 988, the crisis and suicide hotline. This could just be a great resource for folks to have because, we can't be there all the time. And if you've got to go to work to make ends meet and pay the bills, at least giving your loved one something that is a tool that they can use if those feelings start to arise.
And can you tell us what 988 is or does?
Yes. So that would be a crisis line that folks can call in or text to, really to say, hey, I'm experiencing feelings of suicidal ideation. Can you help me? Can we talk about this? And really, these folks are meant to serve as those crisis workers, right? When someone is in really the rut, they're in that worst state, how can we calm them down and get them thinking about something else and then hopefully doing something else?
And is that national? Is that worldwide?
Yes, remains national as of this recording, knock on wood.
Yeah. Okay. And are there other things? Like, is there a moment when we should be like, we're getting in the car, we're going to the ER kind of thing?
Yes, I would say if that person is hurting themselves or having self-injurious behavior, that could be one of the clearest indicators to go and pursue some help. In addition, if we see the person doing something that could be of long-term harm, maybe that's them opening their bottle of pills.
Sure.
Maybe that's them trying to find something to hurt themselves with. We just want to see if we can get in and diffuse that situation before it becomes something more serious, of course.
Sure. So if it feels like, if it's like talk to, if it's sort of a lower level, it's sort of like talk to someone in your life. If it's sort of a medium or more level, it's like you can call or text this number. And if it's a more emergent level, it's sort of like get in the car and go to the ER or dial 911 maybe.
Yes. Great ideas.
Yes. Okay. Are there other, before we get to resources or before we get to supporters, which is how we always talk, other resources that you want to share with us that are available for patients or caregivers that we should be aware of?
A few others. I'd say one of my favorites is mental health first aid. Of course, there are a number of mental health first aid courses available, not just in Minnesota, but across the U.S. Some of these are at low cost, some are at a little bit higher cost, but really do a broad search and see what's in your area, because mental health first aid can be one of the best ways for caregivers to feel confident in having these conversations and how to really even conceptualize, what is suicidality.
Is it a course? Is it a class that?
Yes. And they come from various institutions. So you might find some through your local hospital. You might find others through a community group. And prices are going to vary depending on where you look. So give a broad search.
Interesting.
Never heard of mental health.
I have never heard of that either.
But that,
yes,
I like that.
We should host a class for caregivers. You know what I mean? Like, that'd be amazing.
Totally.
Okay.
And for professionals, I like to recommend QPR. No, they are a specific organization, but the idea being question, persuade, refer. So we're seeing the person come up with suicidal ideation. We're first questioning, why are you feeling what you're feeling? And then trying to persuade the person to think differently about the situation, and then referring them out to other outside resources that could help them with the long-term recovery. Now, that's a little bit more, let's say, higher level. So maybe that's something we ask more of our professionals to lead into, but that can be another great option.
Okay. Other resources, other things that your organizations provide as well that you want to share?
Absolutely. So, of course, us at the Minnesota Brain Injury Alliance and Stroke Association, our big service is resource facilitation, or RF, as we like to call it. Now, what this program is it's free telephone support to anyone in the state of Minnesota that's impacted by brain injury or stroke. When I say free, no qualifying factors, no stipulations, we don't call insurance. So what we do is we reach out to survivors and their families for about 2 years and check in and say, hey, last time we talked, you mentioned you needed a support group, or you needed to get connected with a new physician and help navigate some of those more challenging pieces. Now, one of the awesome things about this program specifically is we have a different one of those facilitators geared towards each of the major regions of Minnesota.
Okay.
So if you're in really rural Minnesota, we'll know what resources are out there, what can we get you connected with. And if listeners are outside of the state of Minnesota, there are about 46 other brain injury alliances or brain injury associations of America. So give a quick search, look and see what's available in your state. And a good majority of states will also have resource facilitation services available. I'll give the caveat, some of these might be called neuro resource facilitation and some might just be resource facilitation, but give a look if you're a survivor on either side, and I'm sure there'd be some supports out there.
Great.
Nice. And then we always like to talk to supporters at the end, right? And so that could be casual supporters like our friends and our family, our neighbors, or it could be, doctors, professionals, that kind of thing. What would you say to folks in our lives about how they could support us as caregivers who might be feeling this, or our loved ones who might be?
Absolutely. I'd say my first tip for the caregivers out there is to focus on the symptoms. If we're seeing the chronic condition and we're seeing the changes in the long term, it can be easy for us to focus more on what's the troublesome behavior or what's the issue we're seeing and not really focusing on what that symptom is. But if we hone in more into the symptom, it can allow us to be more actionable in how it will help the person and really focus more on what are they going through today. How can we be person-centered with, what they have today? Also, making sure as caregivers, we're being a person that our survivor can have hard conversations with. Right. Even if they're hard for them to bring up, and even if we're not the ones bringing them up, giving them that opportunity and leaving ourselves open. And of course, again, making sure we're giving ourselves time to refill our own kettle, to take a step back, do some things that we enjoy, practice some self-care, and really practice creating a life that we don't feel the need to escape from. And probably one of the most important things I'll say. I meet hundreds, if not thousands, of brain injury and stroke survivors every year. And all too often, these folks give themselves so much grief. They'll say, I used to be a primary breadwinner. I used to be a primary caregiver for my parents. I used to take care of the kids. And now I'm struggling to make it to work on time. I'm struggling to get out of bed. I'm struggling to make ends meet. And often the caregiver is feeling pretty comparably, right? They're saying, my survivor is struggling. I'm doing the best I can. How can I do any more? And ultimately, we need to work from where we are and not from where we were. So instead of giving ourselves that unrealistic expectation of when will things be back to baseline? When will everything be back to normal? What are the person's new strengths? How can we highlight those strengths? What are their new limitations? How can we reduce those limitations and keep both ourselves and our loved one as happy and comfortable as possible within that new normal? Now, not always the easiest thing to do, but of course, something we can work towards.
Mm-hmm. You said we give ourselves grief, and I wonder if the opposite of that is grace, right? If we can give ourselves grace to say like, wow, look how far we've come, or wow, look at what we're doing, right?
Exactly. Celebrate those victories, right?
Yeah.
It can be easy for us to say, well, I used to do this before. Why would I celebrate it now? But if you're making progress, hone into that.
Mm-hmm.
Right.
So you said something about, as caregivers, you want the caregiver to be a person that is like sort of easy to talk to or something like that. And so I want to say, to pull that over to supporters, right? So like, what if it's a caregiver or a patient, or what if a caregiver says to their neighbor, hey, I'm noticing this thing in my person, or I'm noticing this thing in myself, how would you want that neighbor to respond?
Totally.
In that situation?
I would first like to say, I love the neighbor to not be reactive to that caregiver, right? It can be easy to kind of jump out of our skin and say, well, how will we handle this? But instead saying, how do you want to handle this? Mm-hmm. If you're the person who's experiencing this issue, how can I be of support to you? And kind of instead of focusing on the issue itself, focusing on how the issue is making us feel and kind of going from there and focusing more on that emotion-focused coping, especially for someone who's a little bit more tangential to the relationship. If you're not a direct caregiver, maybe you shouldn't be given the best advice. Instead, how can you support the person?
Right.
Sure. Yeah. Okay. So much to think about.
Yeah.
And I know we just like only scratched the surface. So I'm so glad that we get to have you back for the support group. Because I think something I just struggle with is like, you don't want to be too reactive, but then also you don't want to be too dismissive.
Exactly.
Mm-hmm.
And so how do we find the line between like taking it seriously enough and getting somebody the support that they need, but also not being like pushing the red button? You know what I mean?
Totally. And I think maybe one of the best ways to kind of keep this conceptualization in mind is I always like to refer to the phrase, once you've seen one brain injury, you've seen one brain injury.
Right.
So just take a step back. Know that this condition is not going to be exactly parallel to another condition, and kind of learning, what the survivor has going on or what the individual has going on and working from there.
Well, Alec, I feel like we've covered a lot of ground, but is there anything else that you wanted to add before we close today?
Maybe just one last thing to wrap us up. So when we're talking about the changes that can come up after chronic condition or after injury, one thing that I always like to clarify on is that the issues that existed prior to the condition or prior to the injury are likely to remain. So let's say the person was experiencing substance use or had depression. Once the condition comes up, that does not necessarily mean those are going to spontaneously go away, right? So we always have to keep in mind what we had going on before is likely to persist. And in fact, with chronic condition, individuals can become more concentrated versions of themselves. And some of these issues can kind of explode or kind of expand into something more serious. And things that they may have had a handle on before might be harder now. For instance, depression, right? If we had mild depression and then we had a chronic condition, that might make those depressive feelings come up more seriously. So don't forget to keep those other outlying conditions in mind. And I especially give this caveat to say, if we've got someone who's recently been diagnosed with a chronic condition and they just left a domestic violence situation, that doesn't make the violence go away, right? So we really have to be cautious into what environment this person is coming from and trying to be protective whenever we can and how they'll come home.
Because like Justin, you've said, like, I had depression going into this. Certainly didn't help. But then my life looked like this, right?
Exactly.
And so I think it's like our life circumstances might exacerbate it. And it might be a moment where we're doing less of the things to take care of that condition, right? And so it's like, might be this double whammy. So that's a helpful reminder.
Yeah. Well, thank you so much for being here with us today, Alec. This has been a good conversation to have, and a
hard one to talk about, but a good one to have.
And I hope that there are listeners who this is helpful for, whether for themselves or for the person they're caring for. And there's the support group for people to come to and kind of dig in deeper if that's something they want to do.
And thank you guys so much for having me. I got to say, before we wrap up, I have been telling so many folks about the negative space and the organization as we've been preparing. And the resounding theme I've heard is, wow, we need that. We need someone who focuses on us and not just on the care of our loved one and not just on the survivorship or the individual. We need to focus on everyone, the continuum of care. So thank you too for all that you're doing to support our caregivers, not only in Minnesota, but across the US. It means a lot to us. So thank you.
Oh, great. And thank you for spreading the word. We appreciate that.
Absolutely.
Yeah. All right. Well, we'll see you with the support group.
Fantastic.
Right.
Thanks,
Bye-bye.
you too.
All right. Bye. You've been listening to In Sickness. Find us online at insickness.care or on Instagram at insicknesspodcast. You can send your questions and comments to hosts@insickness.care. If you enjoyed the show, please share it with a friend or fellow caregiver. Thanks for listening and take care.